Hello, I'm Dr. Darshil Shah, Assistant Professor of Medicine at Beaumont Health System. I'm also an incoming Hematology Oncology Fellow at University of Kentucky. My co-author, Dr. Oksana Dronka, is a medical oncologist at Mayo Clinic, and I had an opportunity to write a review article entitled Latest Advances in Chemotherapeutic Target and Immune Approaches in the Treatment of Metastatic Melanoma, which will appear in an upcoming issue of Mayo Clinic Proceedings. Melanoma is the most dangerous form of skin cancer owing to its metastatic potential and is an important public health concern. The incidence of melanoma has been rising for the past 3 decades. In 2014, approximately 76,000 new cases of melanoma will be diagnosed, and an estimated 9,700 deaths will occur from this disease. Melanoma is potentially curable when diagnosed early, but historically the prognosis of patients with metastatic disease has been poor, with median survival of less than 1 year and overall 5-year mortality close to 90%. Until recently, systemic therapy for metastatic melanoma was ineffective, but the recent successes in the development of new therapies such as target agents and immune checkpoint inhibitors have yielded promising results, changing the continually evolving landscape of therapeutic options for patients with this disease. Melanoma has long been at the cutting edge of immuno-oncology research and is used as a model system for identifying therapeutic biomarkers. In this article, we will review the evolution of the treatment of metastatic melanoma over the past 50 years and discuss the recent 4 FDA approvals in the last 2 to 3 years. First breakthrough was the approval of dacarbazine in 1975, yet it has not been demonstrated in phase 3 trials to improve overall survival compared with placebo and has modest response rate of about 12%. Nevertheless, dacarbazine has been reference chemotherapeutic treatment against which many of the newly developed therapies were tested. Temozolomide is an orally available analog of dacarbazine with comparable efficacy and more favorable toxicity profile, and thus, although not FDA approved, it is routinely used in lieu of intravenous dacarbazine. Multiple other chemotherapeutic agents including nitrosurias, platinum analogs, Winca alkaloids, and taxanes have been evaluated as single agents or combination therapies. High response rates sometimes are achieved with these agents, but that did not really translate into improved survival, and toxicity is an issue. Thus, they have not received FDA approval for melanoma. Recently, a formulation of Paclitaxel, Paclitaxel, has found to be relatively well tolerated with activity in metastatic melanoma. VEGF inhibitor, which is vascular endothelial growth factor inhibitor, bevacizumab, is also being investigated in combination with chemotherapy. In 1998, interleukin-2 was approved with an overall response rate of about 16% with complete responses in 6% of patients. However, high-dose interleukin-2 has been associated with significant dose-dependent toxicity, which limits its clinical utility. Interferon alpha has also demonstrated only modest benefits and is approved for use as adjuvant therapy in the early stages of melanoma. But the durable responses with interleukin-2 highlighted the importance of immunotherapy. The recent molecular characterization of various mechanisms mediated by cancer cells to evade immune detection has sharpened the focus of cancer immunotherapy to develop targeted molecules capable of manipulating tumor microenvironment in favor of an anti-tumor response. The increased tumor specificity of such agents has resulted in better tolerability and more favorable adverse effect profile than that of high-dose interleukin-2. In the article, we will also explain the mechanism of action of these agents. We review recent FDA approval of immune checkpoint inhibitor ipilimumab and discuss the preliminary data of PD-1 inhibitors, nivolumab and pembrolizumab, which has shown 30-40% objective response rates and very impressive durable responses. In the article, we then discuss targeted therapies. Approximately 50% of melanoma contain mutations that activate the RAS, RAF, MEK, or also known as MAPK or mitogen activated protein kinase pathway, making it a prime therapeutic target. Vemurafenib and dabrafenib, which are BRAF inhibitors, are very effective in inducing responses with response rates of about 40 to 50%. FDA also has approved MEK inhibitor trametinib and its combination with BRAF inhibitor. However, resistance develops in almost all patients against these targeted agents. In conclusion, the future has never been brighter for patients with metastatic melanoma, and for academicians and clinicians working tirelessly to improve patient survival. Immunotherapeutic approaches with checkpoint inhibitors and targeted therapies have substantially increased the treatment armamentarium and have revolutionized the clinical approach to melanoma in the past few years. Along with improved therapies and a long pipeline of new molecules and treatment modalities in development, increased collaboration between cancer geneticists and immunologists will be of vital importance to determine the best treatment for each patient. Thank you very much for your time.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.com. This video content is copyrighted by Mayo Foundation for Medical Education and Research.